Okay, guys, we're going to finish up what we did not get to in pharmacology lecture the other day. Um, in Chapter 15, we covered all of the opioid medications, and those being the opioid agonists. We also talked about the partial agonists and the agonist antagonists, but we said that the one thing that those medications could not be were pure antagonists. So Chapter 16 deals with those medications that are the antagonists. So an antagonist competes for that opiate receptor site and blocks the receptor site. This is the way this works is if there is an opioid agonist attached to the receptor site, the antagonist actually has a greater affinity for the site and it will boot that opioid agonist off. And so if you're wondering why would we want this to occur, in the event that somebody is experiencing extreme CNS depression, where they have decreased respirations and decreased level of consciousness, and they're in jeopardy, we could administer an opioid antagonist, which will remove that opiate from the receptor site. So this reverses all effects of that opioid medication. So our intent would be to reverse that suppressed respiratory drive, reverse that somnolence and decreased level of consciousness so they become more alert again and they begin adequate gas exchange. However, you have to keep in mind when you remove that opiate from the receptor site, pain will return, and it will return with a vengeance if it is severe and chronic pain because they no longer have the analgesic effect any longer. If there's no opioid on board or in the person's system and you administer an antagonist, well, then there's no effect because it's not removing anything from the receptor site. It can attach and block, but what is it actually changing? Nothing. So there will be no effect. So after you administer an opioid antagonist, you have to stay with the patient and continue to monitor them closely. So the antagonist works by displacing the opiate from the receptor site. So this little picture here kind of demonstrates that. The opioid is represented by the green sphere, and then we have naloxone or Narcan, which is the kind of the opioid antagonist that we give. So when Narcan is given, it comes along and it bumps that opioid off the receptor site and it takes over. Well, Narcan doesn't stay on the receptor site forever, and the opiate isn't removed from the system. It's just now kind of floating around. So if the half-life of Narcan expires and it begins to wear off, the opioid can reattach to that receptor site, and you can have a return of all of those symptoms that you gave the antagonist to prevent in the first place. So it's very important that you continue to monitor the patient for the return of the symptoms that caused you to give the antagonist to begin with. So we give these antagonists, as I described, in more of a rescue type situation. So if somebody postoperatively is experiencing acute respiratory depression, they're not coming out of sedation well, they have that decreased respirations that would be less than 10 or 12, and some depends on facility protocol, per minute, as well as a decreased level of consciousness. And this will cause a reversal of those opioid adverse effects. It also can be administered if there's a suspected acute opioid overdose. So either accidental or intentional, somebody has taken too many of an opioid medications. Also, police officers carry a nasal spray version of naloxone. So if they find somebody down in the field that's suspected of a drug overdose, they can administer this antagonist. So if they've taken something like heroin or something along those lines, they can give naloxone and hopefully return satisfaction or satisfactory respiration in order to get them medical help before they would expire. Adverse reactions of antagonists, opioid antagonists, are nausea, vomiting, sweating, tachycardia, increased blood pressure, tremor. So if you think about opioids being that super CNS depressant, the antagonists then kind of have the opposite effect with increased heart rate, blood pressure, and possible, shaking and tremors. Do remember that other adverse reactions can be a complete return of the pain experience, somewhat very suddenly actually, as well as the potential to start withdrawal symptoms. The link that I have provided you down here, you can watch. It's a CNN video that shows, a woman who's living in like a halfway house type situation for people that are addicted to heroin, that has, kind of reverted back to drug abuse, and she's found overdosed on heroin. This is a real scene, and you can see them administering the Narcan to her. They have to give her a couple of doses, and then she begins to become revived. So it's kind of an interesting thing to see if you haven't before. Contraindications and precautions and possible interactions of opioid antagonists include obviously a hypersensitivity to the drug. We would not want to give it then. It's not used regularly in pregnancy. We do not give opioid antagonists to infants of opioid dependent mothers. So the quote unquote crack baby that is that's born addicted to the opioids that its mother abused. It would be very cruel to immediately remove that opiate from their system and cause those acute withdrawal symptoms to begin. So there's other ways to treat that type of dependency. As well as with adult people that are opioid dependent. You don't want to just completely strip that opioid narcotic away from their system. They could enter into immediate withdrawal symptoms and experience significant pain if that's what they were kind of self-medicating for or over-medicating for. You also have to be very cautious in cardiovascular disease and with anyone that's lactating, just because of the medication potentially entering the milk glands. Withdrawal symptoms can occur, like I said, if the person is opioid dependent and we remove that opiate from all of the receptor sites. And do remember to read the nursing alerts in the chapter. I've included a couple here, so this is kind of a restatement of what I said before. The opioid may last longer in the system than the effect of the Narcan. So don't just Narcan a patient and then leave them. You have to continue to monitor. They may even require a repeat dose if they begin sliding back into that profound CNS depression. When Narcan or naloxone is used to reverse respiratory depression and that resulting somnolence or decreased level of consciousness, it needs to be given very slow IV push, and you're going to give it until you see a reversal of the respiratory rate and they begin to return to a normal level of consciousness. They begin to become more alert. The intent is never to slam it so the person immediately pops back. It will overwhelm the senses. There's a bigger chance of withdrawal. And again, it can cause that acute pain to come back very quickly and cause a lot of distress to the patient. Before administering an opioid antagonist like naloxone, you need to do some pre-administration assessment if possible. Assess for long-term opioid therapy. Are they somebody that's going to be physiologically dependent, and could you cause withdrawal if you give it too fast or too much? Assess for respiratory depression. We are definitely going to be concerned if somebody has breaths below 10 per minute. You need to evaluate for somnolence or a decreased level of consciousness. Someone may be experiencing respiratory depression, but have an alert level of consciousness so that you can coach them to do some deep breathing and coughing to begin to reoxygenate. We only are going to administer naloxone or an antagonist if they are not able to begin spontaneous respiration on their own because of the possibility of side effects. So don't immediately administer that reversal agent. Try to arouse the patient, try to wake them up. You can do a sternal rub, which is a very deep pressing rub right on the center of the chest, on the sternum, to try to get that person to, kind of wake up, pay attention, take some nice deep breaths. You want to make sure that you obtain vital signs, their blood pressure, pulse, respiratory rate. If they are suffering from CNS depression, all of these things are going to be markedly decreased with respiratory being are most significant and concerning at times. You want to look at the record and to try to determine what's causing the respiratory depression symptoms or the CNS depression symptoms. Look at their health history, allergy history, treatment modalities that they've used, if possible. Now, all of these things are going to be done if time allows, but know that if you find a patient that is breathing very shallowly, respirations less than 10 a minute, you try to rouse them, you shake them, you call their name, you do a sternal rub, and they're not responding to you, we don't take the time to go check the chart, and obviously they're not going to be able to participate in deep breathing and coughing exercises. You need to administer the reversal agent immediately, so don't delay in those situations. After that, you need to know the timeline for monitoring. First, immediately after pushing the Narcan, you're going to monitor the patient very closely every 1 to 2 minutes. You should see a reversal of symptoms begin as soon as 1 or 2 minutes after pushing the medication. If you have not seen a change in their level of consciousness or in their respirations after 2 to 5 minutes, depending on your facility protocol, then you will give more of the medication. You will administer a second dose of that antagonist. After the person begins to become responsive, you're going to continue to monitor blood pressure, pulse, respiratory rate, and level of consciousness every 5 to 10 minutes after that. Because again, we want to make sure that they don't re-slip back into that respiratory depression, because the opiate is still in their system. It didn't go anywhere. It just got removed from the CNS receptor sites. Monitor for any adverse drug reactions and report those to the healthcare provider. Continue to monitor vital signs until the effect of the opioid wear off. That just depends on the drug's half-life, what drug they took, how much they took, and the person's metabolism. So there isn't a set time that this needs to occur. So you're going to have to watch this person very closely for quite a bit of time. There may need to be repeated doses, as I said, if the first dose doesn't achieve a reversal of the symptoms. And then again, restating the duration of close patient observation depends on response to the opioid agonist. So if it works and how much of the opioid remains in their system. Okay, once again, this is an important concept, but it kind of restating, you give this medication slow IV push until the somnolence abates and the respiratory drive returns. We don't want to push this fast. We don't want to push it to the point that the person experiences those adverse effects of tachycardia and high blood pressure, and then especially return of the pain sensation to the nth degree. And we want to be very concerned that we don't instigate withdrawal symptoms. After that, we don't punish this person by saying, okay, whoa, that was a close call. Now you don't get any pain medication again. We still have to assess them for pain. They might be having incredible pain at this point. So you've got to review the circumstances that led to the use of the antagonist. Why did they become overly sedated? What happened? Was it intentional? Does that person need referral to supportive treatments because of intentional overdose? Still doesn't mean that we don't treat their pain. We still treat their pain. What is this person, slipping some of their own pain medications out of their purse while you're administering other things, and do we get too much in their system? Or are they just opioid naive, or the elderly where they just got too much of an opiate built up into their system and caused CNS depression? So we've got to figure out what happened and try to prevent it from happening again, but it doesn't mean that we don't continue to treat the individual's pain. So that's something that you will work out with the provider. You have to educate the patient and family on what happened and why it happened, monitor their fluid intake and output, and that's just for metabolism to help clear that drug from their system. We want them drinking plenty of fluids and passing urine, because that's where the metabolites will leave the body. So as I mentioned, the kind of gold standard or the primary opioid antagonist is naloxone and Narcan, and I do want you to know that. There's a couple other drugs that you're book references, but didn't make it onto the drug table, but it's there in the last pages of the chapter. And I do want you to be aware of them. We talked about opioids in particular, but as we mentioned in the last chapter, alcohol is also a CNS depressant. So the drug naltrexone, which is NALTREXONE, brand names are Revia and Vivitrol, is an opioid antagonist that is given for the treatment of alcoholism. So I do want you to know a few things about this drug. The nice thing about the Vivitrol is that it's a once a month injection, but whether they do the injection or the oral Revia, it's got to be somebody that is interested in rehabilitation. We don't give this medication to someone that's detoxing or prior to detoxing. So it's for the individual that has gone through alcohol withdrawal. They've completed the detox, hopefully, receiving some other supportive type care, some counseling and that kind of thing. AA, whatever the case may be, this medication can be used in conjunction with those types of therapies to support their recovery. What it does is it takes away the ability to feel the effects of alcohol should they partake of it, and it also decreases the craving, so they're less likely to fall off the wagon, as they say, or binge to begin with. So that's a medication I want you to be familiar with. On a side note, there's another type of medication worth mentioning that's specifically marketed as an alcohol antagonist, which is called disulfiram. The brand name for it is Antabuse. Antabuse works a little bit differently than the naltrexone. It's given to, again, an individual that has completed detox and is going through, achieving sobriety. And the way it works is that if alcohol is taken, it causes a profound negative reaction. So the person will experience vomiting, sometimes hypertension, just the most horrible feeling in the world. So it kind of, that person doesn't want to drink because they know while they're on this medication, it's really going to suck. You also have to educate your patients that they shouldn't even use mouthwash that has alcohol in it because it can cause this reaction to occur. So education is very important. The last medication that I want you to pay attention to, also referenced in your book, is buprenorphine. I'm sorry, it's Buprenex or Suboxone, and it's spelled Buprenorphine. This is a partial antagonist, and it actually, if you look back to the med list in Chapter 15, you'll find this medication here. And it can be used to treat opioid dependence while also helping with the treatment of pain. So remember, those partial agonists or the agonist antagonists have properties of both. So this medication is used in treatment of maybe displacing and blocking one type of opiate source, but allowing another one to work. So if somebody, for instance, abused heroin as a, remedy to self-medicate for pain, it could block that particular receptor site while allowing another pain medication for their chronic pain to work. So it just depends on which receptor site is affected by the Suboxone versus which receptor site is affected by the opioid agonist that they're wanting to treat the pain with. So add those to your notes. If you have any questions about any of this, I'll be happy to answer it for you. Otherwise, happy studying.